Alrighty. My name is Bobby Mowry, and this is my intro to CMH presentation on effective communication and intervention, specifically with clients with disability. Quick point of note, the term disability can describe a lot of conditions, even when its own subgroup. So like physical disability, different disabilities within that are like mobility issues like being wheelchair bound, paralysis, cancer is considered a disability, epilepsy, blindness, mental disabilities, autism spectrum disorder, Down syndrome, major depressive disorder, PTSD. These are all examples of different disabilities, and some strategies and interventions may not be applicable or effective for all disabilities. Um, for the sake of research, I kept the presentation topic broad. Um, but yeah, so keep that in note. There will be generalizations in this presentation, but I tried my best to keep them applicable to the most of them. Through this presentation, we're going to go through my rationale for picking this group, applicable definitions, history and background, diversity considerations, legislative actions, and ethical considerations. We're going to talk about communication strategies, effective interventions. Then we're going to go through a client scenario with added discussion points, a client treatment plan for that client, and then we'll summarize, and then we'll get out of here. My rationale for picking this population was that it's an underrepresented population in social media and society in general. Um, they also, physical disabilities overshadow the mental health aspect. So if you see someone in a wheelchair who's not doing good, the first thing you point out in your head is that person's in a wheelchair, not that they look sad or like they're clearly frustrated. That's the major describer. Um, and then also disabilities, whether physical or mental, affect the client's self perception, which requires sensitivity when talking and working with them. And so communication skills matter a great deal with this population. A couple definitions is disability is a physical, mental, cognitive, or developmental condition that impairs, interferes with, or limits a person's ability to engage in certain tasks or actions or participate in daily activities and interactions. So daily activities, interactions, those can be like really big things for some people, like going out to the bars or like driving to work. And it can be like smaller things like being able to cook for yourself, being able to clean. Um, and then accessible just means that something is easily used or assessed by, geez, accessed by people with disabilities, adapted for use by people with disabilities. So if a place is accessible, it just means it's made with people with disabilities in mind. Quick little history and background. In 2022, 28.7% of all adults in the United States have a disability. 13.9% of that being a cognitive disability and 12.2% being a physical disability. So this is a very, like, it's a large group, um, millions of people, and um, this population is very much relevant in society. Now, in 2016, there were 24.6%, which is a difference of about 4%. But when you're looking at a country the size of the United States, that 4% goes out to about 10.8 million people. So in 6 years, that's a large amount. And I didn't do any research. Anything about that is speculative. I would imagine that that has to do with probably redefining what a disability is, and also um, more people being okay saying they have a disability. Um, in recent years, people have been more okay coming out saying they're on the spectrum, autistic spectrum disorder. Um, yeah, so that could be a partial cause. Most racial groups reported 27 to 33% having a disability. So between 27 and 33% of Caucasian people have a disability, 27 to 33% of Hispanics. Interestingly enough, Asian Americans report about 18%, which is looks like significantly lower than most other racial groups. Again, speculative, could have something to do with their culture and um, the willingness to come forward, accept that um, they have a disability. Uh, Male disabilities 26.7%, female disability 30.6%. Again, probably, well, not probably, but could be attributed to the willingness to come forward and admit that you have a disability. Um, Males probably slightly less likely to do that. 18 to 44-year-old, this group, cognitive disabilities are most prevalent. So out of all the disabilities this group could have, 16.2% of those disabilities are cognitive. Now, 44 and up, but really 65 and up, physical disabilities are the most prevalent, with 27.5% of disabilities in this group being physical. That makes sense, right? As you get older, your body shuts down a little bit. It's harder to move, you know, do things in life. Quick considerations is that historically, people with disabilities have been an oppressed minority. A lot of people don't see it that way, but this group has faced exploitation, exclusionism, criticism, and they've been seen as less than human. Um, Common words that we've used growing up, I know I've used these words, like idiot, imbecile. Um, those have historical um, backgrounds of describing people with disabilities. Like an idiot is was someone who couldn't take care of themselves. Um, and also, this is a group that has been just not treated well in the healthcare system. Um, lobotomies were implemented to keep this group manageable. The most significant case I came across was John F. Kennedy's sister, Rosemary. She had, uh, I believe it might have been ASD, but it was some sort of intellectual developmental disorder, and her father, John F. Kennedy's father, lobotomized her. Um, and this is a president in the 1960s. Um, Professionals need to keep this in mind and understand that people with disabilities may have distrust in healthcare systems. And so, yeah, it's just important to keep in mind and understand that the perspectives of some people in this group. Relevant legislative actions. The first, like, major civil rights legislation for this group was in 1979. It was the Rehabilitation Act. Um, it really was just on federal levels, so anything to do with like government proceedings, those were taken care of. But they didn't it didn't fix or like mandate everyday aspects of Life that didn't come until the 90s, 1990, with the uh, all-encompassing uh, Americans with Disabilities Act. Um, it pretty much mandated that any business open to the public or any local, state, or governmental body had to uh, like not discriminate against people with disabilities, but also guarantee that they have the same opportunities, employment, public goods, services, school systems, etc. And in 2008, it was actually brought in to like show what counts as a disability. Before it was like, um, you know, common, not common, but like stereotypical examples of disabilities. Think like amputees or like ASD. But now things like cancer and epilepsy, those things are now considered um, disabilities, as well as a slew of other things. And then, in recent history, there's been steps back for the rights of the people in this group. There's been executive orders to push back DEIA programs, um, and then also the decrease to Medicaid and Medicare funding. A lot of people with disabilities use Medicaid or Medicare, and cutting funding from these directly influences their quality of care. So, unfortunate to see. Um, Ethical considerations. These are just some considerations that are in the ACA Code of Ethics. Stuff like being non-discriminatory towards your clients. Um, and then when it comes to assessing, like giving them a test, like the Beck Depression Inventory or what have it, um, it needs to fit the client, right? So like some tests they need to read, like read questions. If they're blind, they can't do that. So you need to accommodate for the client taking the test. And then those must be noted. Um, um, and then, yeah, when working with the client, recognize what the disability is doing to their situation. And then, uh, if you have websites, make sure those websites are accessible. Things like text readers, which can be on different programs, but um, or like things on the individual's computer, but those are just considerations that should be made. All right, communication strategies. So, in general, clients with disabilities do not feel like healthcare providers or counselors, for that matter, are prepared to treat or understand them. Um, Common feeling that it's almost like perhaps like an African American person would feel this way about a white counselor, in the sense that you can't understand my life and what I've been through. Similar. Um, can be helped by patient-centered care and emphasizing respect for the patient's preferences, needs, and values. So just, you know, making sure that the client is the expert in their situation and understanding what they want and what they need. Um, and don't make any assumptions about what the client wants, right? So if someone is wheelchair bound, their main priority might not be getting the ability to walk, essentially. Don't assume that that's just what they want to do. And then uh, to also help combat like the dissonance between client and counselor, building rapport and trust, right? So this is applies for pretty much every client, but specifically applies to this because it will help kind of bridge the gap between where the counselor and the client are at. Um, Inappropriate interventions. Every theory has its merits when working with disabilities. Some work better than others. Um, and again, it's like case by case, but these are some broad strokes that could help. Person-centered therapy, like we were talking, um, with communication strategies, um, it's useful for creating a safe and trusting relationship and allowing this person to know that you're on their team and you want the best for them. Cognitive behavioral therapy is good for breaking dysfunctional cognitions like self perceptions and worldviews. Um, the way that someone with a disability sees themselves might not be good for them. And, ways that they think the world is looking at them also might not be good for them. Um, and adjusting negative behaviors. So, they might not want to go out. They might want to stay at home, isolate themselves. They might be angry with their situation. Um, CBT could help manage some of those behaviors. Then reality therapy slash choice theory. Um, this is a big one. I think it'd be really useful for having the client understand what they can and can't do and what they could possibly do, um, and gives them a control over their own happiness. Speculatory, but it seems like a lot of people with disabilities, especially if they were born or not, um, feel like they didn't really have a choice. Reality therapy can help give them a little bit of control and choice in their lives. Um, yeah, I guess I was kind of like no one chooses to have a disability, but um, it doesn't matter. And can increase sense of autonomy. Uh, just continuing different modalities of therapy. These can all be good in their own ways, and um, so group therapy allows people to connect and allows people to kind of, come together in their um, mutual understanding of what it's like to have a disability. And even if the disabilities are different, they still might have similarities in how those disabilities have affected them. Um, and also, it's an opportunity to get out and be with people, especially people that understand you. Individual therapy, I just put this on here because it's you can suit the need of the client with how diverse and how many disabilities there are. Personalization is like honestly super important for someone with a disability. And then family therapy is just it's a way to kind of um, like help the family unit manage and live life with someone with a disability. Um, yeah, what works, what doesn't work, what's okay, what's not okay, things like that. So my client scenario is a 28-year-old white male named Jordan who was diagnosed with cerebral palsy at the age of 2. At home, Jordan uses crutches and in public uses a powered wheelchair. Jordan experiences chronic muscle stiffness and pain, as well as fatigue from physical exertion, and also a side effect of his medication. Some psychological factors include increased anxiety while Jordan's navigating social perceptions of him and his cerebral palsy. Jordan also reports feelings of frustration and low mood tied to his physical limitations. Jordan expresses strong internal motivation for independence as well as good coping skills such as journaling. Social factors, Jordan lives alone. His apartment is accessible. Jordan has experienced conflict with his employer. He doesn't feel that his workplace is sufficiently accessible for his disability, and also his employer has repeatedly scrutinized him for being late due to limited public transportation options. Jordan does have a supportive friend group, but strained family relationship due to his parents being overprotective and limiting. The presenting problem is Jordan comes to therapy seeking support for anxiety, workplace challenges, and balancing independence with accepting help. Some things to think about while we go through this case is how might Jordan's physical limitations affect therapeutic intervention? What are things that we can and can't do? What strategies should be used as to not reduce Jordan to his condition? It's more of a technique thing. How do we not say Jordan, the cerebral palsy person? You know what I mean? Like it, understand that through treatment we have to show Jordan that, or we'll have Jordan see that he's more than his condition. And then, in what ways could a counselor advocate for clients like Jordan? What can we do either, in social spheres or in government? Like, what can we do to help our clients outside of the session room? So the treatment plan, I decided to do individual. Um, if Jordan was like rather isolated, I could have done group. Um, Also, family could have been all right, but I figured for this specific case, individual sessions just made sense, especially again for that personalization aspect. Um, don't have really you know, a rhyme or reason for the frequency. Weekly just seems fine. I didn't see a need to do more or less. Again, 3 months adjustable. And then I would use a combination of CBT and reality therapy slash choice theory. So in the initial phase of treatment, would boil down to starting by making sure that the room and building are accessible to Jordan. If he's coming to the session in his powered wheelchair, I need to make sure that he's able to get in the building, in the room, and in a comfortable spot. Um, so yeah, begin by building rapport and learning about Jordan. Learn about his goals, values, preferences. Um, what he likes, what he doesn't like, what he wants to be, what he doesn't want to be. And also learn about his views on the world and himself. How does he see himself? Um, how does the world see him? How does he see the world? Then learn about how cerebral palsy has affected his past and how he thinks it impacts his future. If Jordan's comfortable, I would utilize the Beck anxiety inventory. Um, he talked about his anxiety, so that's a way to actually measure it. And, you know, at the end of the 3 months of treatment or however long we could take it again and see if there are any measurable effects of treatment. I'd also use the Tennessee self-concept scale. Um, Again, self-perception is a big thing with this group, but specifically with Jordan. Um, so again, that's a test to have measurables in treatment. Um, so the working phase of treatment, I have 3 goals. Jordan has 3 goals. First one being, I want to feel less anxious in social settings. To achieve this, the first objective is in session, we would identify 3 practical soothing interventions Jordan can do while anxious. More of a security blanket, bandage to the problem, but to help him, you know, get through social environments. Um, Not hating it, these would be, good to use. Objective 2 in session, identify dysfunctional cognitions that are creating Jordan's anxiety. Anxiety is the anticipatory reaction to things in the future. So identifying what those things are and where they're coming from. And some homework that I was assigned to Jordan is over the next week, I would want him to realize, identify these dysfunctions and think of 2 ways they are incorrect, things that they could be proving wrong. Is he overgeneralizing? Is he using black and white thinking? Things like that. And objective 3, create a plan for Jordan to be in a social setting like a restaurant, a park, a store, and strike up conversation with a stranger in the next week. This could be super stressful, but it's a way to expose himself to social settings, social environments, and kind of put away any anxiety that he might have. Goal two is I want my boss and I to have an understanding relationship. In session, I would want to work with him to create a plan to talk to his boss, explain his tardiness issues, um, and express concerns about accessibility in the next week. And I would like to role play this. Again, if he's anxious in social settings, I think role play would be a really good way to prime him for a conversation that might be kind of uncomfy. And then goal three is I want to feel okay with getting help. Um, in the next 2 weeks, I would have Jordan write down 10 things he could do for himself and 10 things he cannot do for himself. Um, and then for the things he can do for himself, rate on a scale of 1 to 10 how easy they are for him. This is kind of show that if he can do something for himself, but it's a 1 on the easiest scale, um, it's really, really hard for him. He can do it, but it's hard. Maybe we could talk about if he wanted to, you know, how okay it is to get help with that, And for the things he cannot do for himself, rate on a scale of 1 to 10 his comfort level for getting help. How does it feel to have to ask for help? Again, it's things to kind of help him feel okay getting help. Um, putting things on pen and paper and analyzing and realizing comfort levels, you know, how easy things are for him. So yeah, in summary, I introduce a topic by explaining the rationale, history, background, diversity considerations. We went through some legislative actions as well as things to consider in regards to ethics. We explored effective treatment, uh, therapeutic practices through communication strategies and appropriate interventions. And then we talked about Jordan in the case scenario and his treatment. And then here is my reference page. Thank you for paying attention.